Evening to all of you, and thank you for joining us on yet another PeMSAA evening talks, where we have exemplary alumni giving us a helping hand, particularly for you all. Today, this evening, we will be having a session on psychiatry, and it will be on a very important topic, schizophrenia, what you need to know. This is from, of course, an exam point of view. And it's my great privilege to introduce my friend, Dr. Anuradha Ellepola. He is the consultant psychiatrist at the Teaching Hospital Anuradhapura. He's volunteered to help out this evening by discussing some of the management points or history points in the history, mental state management, pitfalls, and where you lose marks, where you can score more, etc. Because he is an examiner. He's a regular examiner at the final MBBS exam. I think most faculties, isn't it, Anuradha? You come to PeMSAA every year, but he's an examiner at almost all the faculties. So he has a lot of it to have this discussion with you. Feel free to, Anuradha, I think they will be asking questions and clarifications at some point. You can... that's okay with you, right?
Because yes, of course. I think it's really good.
So feel free to ask Sir any clarifications, anything that's not clear, and I'm sure he'll be happy to help you out. Yeah, so sure. Without taking much time, Anuradha, the stage is yours.
Okay, sir. Thank you so much.
Okay.
And thank you so much, my beautiful friend, Sayur Pereira, for inviting me to do this lecture on schizophrenia. Yeah, so I'll start sharing the slides. Okay, can you all see the slides?
Yeah, we can see.
All right, okay, thank you. Yeah, so as my friend Sayro said, it's very important to discuss about schizophrenia because in the exam point of view, it will be very important. And when you become house officers, schizophrenia will be very important because you will see patients with schizophrenia in your daily practice. And you will have to see the patients, manage the patients, refer the patients with schizophrenia. And if mismanaged, it will be a problem. Right? And if you misdiagnose schizophrenia, it's again be a problem. So you better know important things about schizophrenia before you become doctors, house officers. So, and also, as Sarah mentioned, exam point of view is very important for your long cases, for your structured essays. You'll be getting cases of schizophrenia, and you'll be asked about the diagnosis, management, and you'll have to present patients with schizophrenia in the exams. So that's why we selected this topic today, the evening lecture. Yeah, so Peradeniya is very important to my life. Is like my second home. I spent many years, like 5 years in the medical faculty as a medical student, and again as a house officer at Peradeniya Teaching Hospital. And there are pioneers and there are legends in medicine, surgery, pediatrics, genomes. And it's a time that we never forget. And I consider Peradeniya as the most beautiful university in Sri Lanka. And it's my great privilege to be here talking to the Peradeniya alumni as a lecturer, doing a guest lecture here. Again, I would like to thank my friend, Dr. Sayur Pereira and PeMSAA for inviting me to do this lecture. Right. So if you talk about schizophrenia, what is schizophrenia? And it's a very complex disorder. Right? Schizophrenia, understanding schizophrenia is not easy. There are patients with complex problems related to schizophrenia, and people still don't know very much about schizophrenia. Still, people are getting knowledge about schizophrenia. Management is still not in optimal level. So it's a very complex disorder, and we have to learn many things more about this disorder. And we'll be seeing more papers coming up about this disorder. It's very complex. It's neurology, like the brain itself, is very complex. And when you take schizophrenia, it's even more complex. Right? And it's a neurodevelopmental disorder. Right? It's a chronic neurodevelopmental disorder. And if you look at the neurodevelopmental disorders and neurodegenerative disorders, there's a big difference between the two. The classical example of neurodegenerative disorder is the dementias, like Alzheimer's dementia. And there's degeneration of neurons, and there's meiosis, replacing the weakening neurons, and the disorder is progressive and is deteriorating. Neurodevelopmental disorders are, on the other hand, different from neurodegenerative disorders. Neurodevelopmental disorders like schizophrenia, and you can see changes in the brain from the patient's childhood or even adolescence, right? And there's no degeneration of neurons like in like in dementias, and there's no gliosis. The glial process is not there. So if you look at the brains, there are PET studies, MRI studies done on schizophrenic brains. They find that the changes in the brain, the structural changes in the brain, they are present from the early life, and it's a neurodevelopmental disorder. It happens during the neuronal development. And when the disease is active, it can be characterized by episodes when the person is unable to distinguish between the real and unreal experiences. That's when the psychopathologies like delusions, hallucinations, thought disorders are coming to the picture. They don't know what's real and what is unreal. I'm sure some of you may have seen the movie The Beautiful Mind, and they show the difference between a real experience and an unreal experience. They actually feel that, they actually perceive, they actually believe that. Right? They believe the unreality, they perceive the unreality. So it is a disorder where the person is unable to distinguish between the real and unreal experience. So if we take the history and evolution, if it goes back the before Christ period, even in Egyptian papyrus, you can see some description of illness like schizophrenia. In the 17th century, they were talking about these episodes of madness, right, involving hearing voices, seeing visions, and also the experience of this unreality. It was first described by Dr. Emil Treppel in the 19th century. And he first used the term dementia precox or premature dementia to describe schizophrenia. And Eugen Bleuler is the one who developed Treppel's ideas on this disorder, and he first used the term schizophrenia. When you pronounce schizophrenia, there's a T when you're pronouncing schizophrenia. Schizophrenia is like pronouncing pizza, right? There's a T. It is not there when you're writing the term schizophrenia, but to pronounce schizophrenia. And after that, they started to learn a few things about schizophrenia. And earlier, they thought patients with schizophrenia are dangerous, and they built up some asylums, especially in the Bethlehem Asylum, and it was one of the largest asylums in the world during that time. And later, they expanded the asylums. They wanted to keep the patients from in because they believed patients with these disorders, mental illnesses, especially schizophrenia, are dangerous. They thought patients should not be kept in the community with others. Right? And there was a lot of stigma attached to illnesses like schizophrenia. The stigma is still there, and stigma is there on mental illnesses as well. It's slowly going down, slowly decreasing, but still there's a lot of stigma on these psychiatric illnesses. And then later, people like Pinel, they dechained people in the asylums, and they started to keep patients in the community, dealing with the others in the community. So they were against this concept of asylums, and they started to build up hospitals and also started to keep patients in the community with others. So this the favorite preparing in the first picture, and Swiss psychiatrist Eugen Bleuler, and he turned schizophrenia in 1911. And these are two gentlemen who first used the antipsychotic chlorpromazine in psychiatry to treat schizophrenia. Chlorpromazine is the first drug that was used to treat schizophrenia. We are still using it. It's a wonder drug. It's a very nice drug. It has some sedative properties. It's a good antipsychotic, right? And still it's efficacious to treat schizophrenia. And we don't use it very often these days because we have other antipsychotics such as olanzapine, risperidone, or amisulpride, cotripine. But chlorpromazine is still useful for some categories of patients. If you take epidemiology, the different books, different literature give different uh, ideas about the epidemiology of schizophrenia. And the common consensus is that the prevalence rate of schizophrenia is just below 1%. That's if you take the prevalence range is from about 2.7 per thousand to 8.3 per thousand. So it is just below 1% in the community. And if you take the incidence is very much lower when compared to the prevalence because schizophrenia is a very chronic illness. When the patient develops schizophrenia, it prevails with the patient for life. And the disorder itself is not reducing the life expectancy of the patient. Patient can live to the expected number of years, maybe 8 years, maybe 9 years. Right? And schizophrenia itself is not reducing the life expectancy of the person. So it's a chronic illness. So prevalence is very much higher when compared to the incidence of schizophrenia. So we take the incidence is about 10 times lower when compared to the prevalence. So the range can be taken from 0.1 per thousand per year to 0.7 per thousand per year. In Sionpi's classic study, about half had an undulating course with partial or full remissions, followed by recurrences in an unpredictable pattern. About one-third had relatively chronic unremitting course with poor outcome. And only a minority in the study had a steady pattern of recovery with good outcome. So only a minority had a good prognosis, good outcome in patients who develop schizophrenia. So you can see the schizophrenia is still having a poor prognosis even after discovering some newer medicines, right? And there are other treatment modalities for schizophrenia, but still it is having a poor prognosis. So it is one of the reasons why schizophrenia is attached with a lot of stigma. Prognosis is not that good. Right? People do not like to say that they have this illness. Right? Even if it comes to certain social circumstances, people get cornered when they have schizophrenia. One of the reasons is because it has a poorer prognosis when compared with some of the other disorders. If you take female to male ratio, the males have a slightly higher incidence of schizophrenia when compared to females. It is taken as 1.4 to 1 male to female ratio. And some of the books says 1 to 1, but the common agreement is it is slightly higher when it comes to males. And if you take the classical age, the typical age a patient develops schizophrenia, in males, they have one peak. Females do have two peaks. Usually, both males and females are developing the illness, usually around the age of 20s. Males are developing the illness slightly at an earlier age, at around 20 to 24. Females develop it at the age of around 25 to 29. That's the typical age of developing schizophrenia. But we usually see patients developing the condition in other ages as well, earlier ages as well as in later in life. In contrast to males, females do have two peaks of developing the illness. Females again have another peak at the age of around 45 to 49. So you can expect females who are having vulnerability to develop schizophrenia, develop the disorder at a later age as well during the menopausal period. If you take the etiology, as I mentioned, schizophrenia is a very complex disorder. There are biological factors, psychological factors, and social factors influencing this disorder. And the etiologies, right, there could be both a combination of biological, psychological, and social factors. Just because a patient is having genetic predisposition doesn't mean that he's going to develop schizophrenia. There should be other factors affecting the patient as well. We call them predisposing factors, precipitating factors, and perpetuating factors. If you take the biological factors, the main biological factor is the genetic predisposition. If you take heritability, that is the genetic influence on the disorder in a population, it has around 80% of heritability. So genetic predisposition is very important. We are taking history. If you are given a patient with schizophrenia in the exam, it's very important to ask about the family history of schizophrenia. Whether any siblings are affected with schizophrenia, whether there are any first degree relatives affected with schizophrenia, because it has a very high heritability. Genetic predisposition is very important as an etiological factor. When compared to the biological factors, the psychological and social factors are less predominant as etiological factors in schizophrenia. On the other hand, if you take anxiety disorders and some of the mood disorders like depressive disorders, mild moderate depressive disorders, reactive depression, there are environmental, social, and psychological factors affecting those illnesses more. Schizophrenia, biological factors are more important when compared to psychological and social factors. So this is the person who first described the Biopsychosocial Model. It's George L. Engel in 1977 explained psychiatric disorders by the biopsychosocial model. That is, there are biological, psychological, and social factors. So in the exam, when you write an essay or if you see a patient with a disorder, you always try to find why this particular person developed this illness at this moment. What are the biological components, what are the psychological components, and what are the social components that would have given rise to the onset of the illness. So you have to take a very comprehensive history. So this biopsychosocial model explains the complex interplay of three major dimensions: biological, psychological, and social dimensions in developing the psychiatric disorders. And a person does not suffer as isolated organs, but rather as a whole. And it provides a holistic approach to psychiatric illnesses. And emotional tone of a person, the personality, the environment, and other social parameters influence the manifestation of illness. And if you take the etiology, nobody has found a single cause for this disorder. We see in when we do medicine and surgery and in pediatrics, sometimes we see disorders that are being influenced by a single factor, a single cause. But schizophrenia, as we discussed, is a complex disorder, and there are biological, psychological, and social factors. So it is difficult to identify a single cause for the onset of schizophrenia. There are multifactorial, it's a multifactorial disorder. There are so many factors interacting with each other and giving rise to this disorder. If we take these factors, one thing is the genetic factors. And they have found some genes like certain genes like neuroleptic dysbinding, right, affecting the schizophrenia. Right? And they are making the person vulnerable, genetically predisposed to get the disorder. And there are biochemical factors, mainly dopamine, glutamate, and serotonin. That's why the medicines that are making the person improve of the illness are mainly affecting these neurotransmitters, dopamine, glutamate, and serotonin. The imbalance between these chemicals can give rise to the illness and also can make the patient vulnerable to getting the illness. And there are family relationships affecting the illness. Some people with schizophrenia are sensitive to familiarity and high expressed emotions. This high expressed emotions is very important when you are talking about relapses of the illnesses, especially conditions like schizophrenia and depression. And there are three main high expressed emotions we are talking about. One is the hostility, and then over-involvement, and then criticism. So sometimes we discharge patients home, and in just another couple of days, the patient comes back and get admitted. So the patient has a relapse. When you are discharging the patient is completely normal. The patient is in a remission, but the patient comes back in just a couple of days with the recurrence, relapse of the illness. So one of the reasons do you hear me? Hello.
Yeah, we can hear you.
All right. Okay, thanks. That's a message. Yeah. So some people with schizophrenia are sensitive to these high expressed emotions. So there's a belief that in Asian countries the expressed emotions are low when compared to other countries like Europe, Australia, and America. It seems that in those countries the expressed emotions are a bit higher when compared to countries in Asia. So that it affects the relapsing of schizophrenia. And also stress. We all undergo stress at work, as medical students, during the exams, we all undergo stresses. And sometimes you see people develop psychiatric conditions just after stressful life events. So schizophrenia is also a condition, another condition that can get a relapse or can appear for the first time in life after a stressful incident, especially in vulnerable individuals. If there's a genetic predisposition or any other psychosocial predisposition, they can develop the disorder after a stressful incident, stressful life event. Maybe after an exam, maybe after a stressful incident like marriage, divorce, right, separation, bereavement, and those can act as precipitating factors. Right. And people with schizophrenia often become anxious, irritable, and unable to concentrate before any acute symptoms are evident. So there's a time when the patient is getting the illness, there's onset of illness or the relapse of illness. And just before that, you see patients show early warning signs of relapse. We call them early warning signs. These early warning signs are different from one person to the other. So we call them disease signature. Your signature is unique to a person, just like that. The early warning signs of relapse could be very unique to a particular person. Then they are relapsing, or when they are getting the first episodes of schizophrenia, they get the disease in a particular unique manner. That is called the relapse signature. So usually, patients become anxious and irritable, and they are unable to concentrate before the onset of the acute illness or before a relapse. Right? And this can cause problems in work or study, and also in relationships. And you can clearly see a deterioration of the patient's level of functioning before the illness. And after some time, when they develop the illness, there's further deterioration. That's why in DSM-5, they're always talking about this deterioration in diagnosis schizophrenia. So we'll go to that later. And also substances, especially cannabis. Right? We see a lot of patients abusing cannabis in Sri Lanka. There are high concentrated cannabis like KG, that is called Kerala ganja, right? There's high concentration of 9-delta tetrahydrocannabinol, right? And that can act as a precipitant for schizophrenia, even in non-vulnerable individuals. Usually vulnerable patients, after taking cannabis, even a single dose of cannabis can get a disorder. and people who are not vulnerable to develop schizophrenia. As an example, those not having a genetic predisposition to develop schizophrenia can develop a psychosis or even schizophrenia after taking cannabis for some period of time. So it is not a good idea to abuse cannabis. And people with schizophrenia are more likely to use substances. And as I mentioned, people who use substances like cannabis are more vulnerable to develop psychosis. And the other way around is also true. People with schizophrenia are more likely to use substances. There are so many reasons for that. As an example, people get negative symptoms and extraordinary side effects when they're taking medicines for schizophrenia. And to relieve them temporarily, they take substances. Like they sometimes take cannabis, sometimes they uh, smoke cigarettes to get rid of the symptoms and also side effects of medicines. So schizophrenics are more likely to use substances than others. A significant proportion of people with schizophrenia smoke, which contributes to poor health. So as I mentioned, schizophrenia itself is not reducing the life expectancy of a person. But other related problems, like when they smoke cigarettes more often, right? When they are not adherent to a healthy lifestyle, or when they get suicidal ideas because of the illness, right? That can contribute to poor health and also cardiovascular manifestations. There's higher cardiovascular risk among schizophrenics, especially when they're on medications. And also smoking also contributes to that, and they can develop ischemic heart disease and even strokes more often than others. So this is a summary of the neurochemistry of schizophrenia. You all might have heard about these four pathways: mesolimbic pathway, mesocortical pathway, nigrostriatal pathway, and tuberoinfundibular pathway as neurochemical pathways of schizophrenia. You must have learned it in the pharmacology in third or fourth year, right? So if you take mesolimbic pathway, mesolimbic pathway is the main pathway in the brain that gives rise to positive symptoms. And we'll talk about positive symptoms later. So there's dopamine excess in the mesolimbic pathway, and it can cause illusions, hallucinations, and tone disorders in people with schizophrenia. If we take the mesocortical pathway, blocking dopamine receptors in mesocortical pathway can give rise to negative symptoms. Negative symptoms. And then nigrostriatal pathway, when you block dopamine receptors in nigrostriatal pathway, it can give rise to extrapyramidal side effects like acute dystonias, rigidity, tremors, Parkinson's in patients who are taking treatment for schizophrenia. The last pathway, which is the tuberoinfundibular pathway, getting dopamine receptors blocked can give rise to hyperprolactinemia symptoms. There could be gynecomastia, menstrual disturbances in females in childbearing age, right? And then galactorrhea. Right? Those are very distressing symptoms for patients. So mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular pathway. Excess of dopamine in mesolimbic pathway give rise to positive symptoms. Blocking of dopamine receptors in mesocortical pathway can give rise to negative symptoms. And blocking dopamine receptors in nigrostriatal pathway can give rise to extrapyramidal side effects. And blocking dopamine receptors in the tuberoinfundibular pathway can give rise to hyperprolactinemia symptoms. So if you take main symptom categories of schizophrenia, we can cluster them into four main symptom clusters. Those are positive symptoms, negative symptoms, disorganized symptoms, and cognitive symptoms. We call them positive symptoms because those symptoms are abnormally present. As an example, hallucinations and illusions. The definition of hallucination is for you, like in the exam, if you are asked what the hallucination is, then you have to give the definition. So hallucination is a perception without an external stimulus. There could be auditory hallucinations, visual hallucinations, right? And tactile hallucinations, gustatory hallucinations, olfactory hallucinations, somatic hallucinations, and there are special types of hallucinations like extracorporeal hallucinations, hypnagogic and hypnopompic hallucinations, right? And otoscopic hallucinations. Like that, there are reflex hallucinations, functional hallucinations, there are special types of hallucinations as well. And another positive symptom is a delusion. Delusions are uh, firm, unshakable beliefs. Those are not amenable to reason. And people held them in absolute conviction. And that is not keeping with the patient's social, economical, educational, cultural background. So if you are asked for a definition, if you say the examiner that you elicited delusions in the patient and the examiner might ask you what the delusion is, then you have to give the definition. So we have to remember what a delusion and a hallucination are. Right? And the third type of positive symptoms are the thought disorders. There are formal thought disorders. So again, formal thought disorders are very important in diagnosing the psychotic illness, especially schizophrenia. So there are formal thought disorders like derailment, night mode thinking, circumstantial thinking, right? And loosening of association. Right? So there's a disorder in the thought process. So those are the positive symptoms. If you take negative symptoms, we call them negative because those symptoms are abnormally absent. As an example, the loss or decrease in the ability to initiate plans, speech, there's positive speech, there's poverty of speech, their mood is very blunt, right? And they can find pressure, they are very slow, right? So those are negative symptoms. And the mood is very important in schizophrenia and in other disorders as well in psychiatry, right? When you're doing the mental state examination, you have to elicit the person's mood. Mood is the reflection of the emotional response of the patient. The reflection of the emotions of the patient. So if the patient has negative symptoms of schizophrenia, they might have a blunted effect, blunted mood. Right? The effect is very restricted. The effect is the short-term changes in the emotional response. Mood is the long-term emotional changes in the person. Right? So you can see patients with negative symptoms have a very restricted effect, and the mood is that the predominant uh, expressed emotions are very blunted. Right? And there are disorganized symptoms. Patients can be confused, perplexed, right? And they can have disordered thinking, speech, and they have trouble with logical thinking. And sometimes they show bizarre behavior, or abnormal movements. There could be stereotypies, mannerisms present in these patients, right? And they are very disorganized. And lastly, patients can develop cognitive symptoms, and they have problems with attention, concentration, memory, and thus declining of educational performance. So today I saw a patient who's an engineer, right? And he developed schizophrenia at the age of around 22. And then since then, there's a deterioration of his level of function. He became an engineer, right? And then he relapsed again and again, right? Due to stresses. Right? Even though he developed the condition after his A-level exams, he got through it without any problem, right? He became an engineering student, right? Right? And then uh, after the first episode in his 20s, right, he developed the relapses later in life. In 30s, now he's around 40, right? And there's a very significant deterioration of his level of attention, memory, and he could not uh, do his exams, any further exams, because his memory was poor. Right? There's a declining in educational performances, academic performance, as well as work performance. Actually, he lost jobs a couple of times because his concentration, memory, and the performance was poor after developing the condition. And not only the disorder, but also some of the medications we use to treat schizophrenia can affect the cognitive abilities of patients. Right. So when you're talking about symptoms and signs of schizophrenia, Kurt Snyder, a German psychiatrist, proposed the first rank symptoms in 1959. The 20th century, he proposed the first rank symptoms. So one of the common mistakes we see in the exams is that medical students come and say the patient is having schizophrenia because the patient is having first rank symptoms. What we actually expect from you is to talk about diagnostic guidelines like ICD-10 criteria and DSM-4 or 5. Now the current DSM version is DSM-5, right? And ICD is also like very soon they'll be having ICD-11 diagnostic guidelines. It is out there and it is still being revised, and we see so many changes being done to ICD-10 when you come to ICD-11 diagnostic guidelines. So don't say the patient is having schizophrenia before the patient is having Snyder's first-rank symptoms. Schizophrenia is a syndrome. You can't diagnose schizophrenia by the presence of just one symptom or sign. You need to have a syndrome. ICD-10 and DSM-4 or DSM-5 are talking about a syndrome, right? You need a collection of right, different manifestations to diagnose it as schizophrenia, right? So, Snyder's first-rank symptoms are these audible thoughts, right? And that is voices being thoughts aloud, right? Thought echo, right? And voices arguing. Those are the third-person portrait hallucinations. Voices commenting on one's action. The voices are describing subjects' activities as they occur. And influence playing on the body, somatic passivity, or delusions of control. And there's thought withdrawal and thought insertion. Thought broadcasting is when the person is strongly believing that his thoughts are known by others. And there's made feelings, made impulses, right? Made volitional acts, and delusional perception. This delusional perception is a two-membered delusion, right? In delusional perception, there's a perception and there's a meaning given to that perception. That meaning is the delusional meaning. And it is not related to each other as well. As an example, when the patient is walking on the street, right, he may see a flag and he will suddenly get the thought, right, that the thought, the belief that there's a conspiracy going on and some people are trying to kill this person. It is not related to the flag, right? But when he sees the flag, when there's a clue, he gets the delusional perception. So we call it a two-membered delusion. There's a perception, there's a clue, as well as a delusion. So Kurt Snyder said the presence of these symptoms, actually the presence of a single symptom is diagnostic of schizophrenia. But later, when the diagnostic guidelines in practice, they changed the diagnostic criteria, and they came up with different criteria, and they said this number of criteria need to be present to diagnose schizophrenia or depression. And if you take ICD-10 criteria, they have divided schizophrenia into different types, like paranoid schizophrenia, hemophilia schizophrenia, catatonic schizophrenia, and simple schizophrenia. If you take paranoid schizophrenia, the predominant symptom of paranoid schizophrenia is the paranoia. Those are like hallucinations, delusions. They can have perceiving delusions, delusions of control, bizarre delusions. That's paranoia, the prominent paranoia. On the other hand, if you take a disorder such as simple schizophrenia, they have prominent negative symptoms. So if we take the prognosis of paranoid schizophrenia is always better when compared to other schizophrenia such as hemophilia schizophrenia, catatonic schizophrenia, or simple schizophrenia. Simple schizophrenia has a very poor prognosis when compared to other disorders because they present with negative symptoms. They are insidious onset of negative symptoms without manifestations of prominent positive symptoms. So we can get an idea about the patient's outcome, patient's prognosis by categorizing into different types of schizophrenia. So these are the ICD-10 diagnostic criteria. In the exam, if you get a patient with psychosis, right? If you ask why you say the patient is schizophrenic. You would say my first differential diagnosis is schizophrenia. Then the examiner would ask why. Why do you say that? Then you would have to stick to one of these diagnostic guidelines, ICD-10 or DSM-5. But most of the time, I'm sure that you are more familiar with ICD-10 diagnostic criteria. That's fine, right? You can say, because these criteria are present, I manage this patient as for schizophrenia. My first differential diagnosis is schizophrenia, right? And if you take ICD-10 diagnostic criteria, it relies more on Snyder's first-line symptoms. But they have included other criteria for the diagnosis as well. If you take the criteria A, they talk about thought echo, thought insertion, thought withdrawal, and thought broadcasting. The second criterion is delusion of control. Then you have another hallucination, third person auditory hallucinations, voices giving running commentary, or voices coming from a part of the body. Then criterion D is the culturally inappropriate and completely impossible delusions. We call them bizarre delusions. Right? It's completely impossible, inappropriate, right? Bizarre delusions. So according to ICD-10, presence of at least one of these symptoms from A to D for more than 1 month, right? For more than 1 month is good enough to diagnose schizophrenia. And sometimes you see patients with these symptoms for a brief period of time, maybe for just 1 week or 2 weeks. Right? Then we call them brief psychosis, or DSM, or we call them acute transient psychosis. There are so many types of acute transient psychosis, like acute transient polymorphic psychosis, like schizophrenia, and there are so many types of acute transient psychosis. So when the duration is not there, we don't call it schizophrenia. We can't diagnose schizophrenia because the disorder is different, the process is different, the prognosis is different, and it depends partly on the duration. And then apart from that, there are E, F, G, H, and I criteria, like thought disorders, negative symptoms, other types of hallucinations, right? And social drift. So the last criterion, criterion I, is applied for simple schizophrenia. So it is different from other criteria in ICD-10. So the last criteria, they say there's a deterioration of the level of functioning for more than 1 year. That last criterion, criterion I, is applied to simple schizophrenia. I mentioned that it's a type of schizophrenia with a poor prognosis. So to diagnose it as simple schizophrenia, you need to show the deterioration of the level of functioning for more than 1 year. So if you take DSM-5, their criteria are different when compared to ICD-10. So they also talk about hallucinations, delusions, thought disorders, catatonia, and negative symptoms. And the duration is same for 1 month or more. But they don't specify the delusions or hallucinations. In ICD-10, they specify. They are talking about bizarre delusions, illusions of control, right? Thought insertion, withdrawal, echo broadcasting, right? Third person auditory hallucinations, and hallucinations giving running commentary. But in this one, DSM, they don't specify the hallucinations or delusions. Presence of these symptoms for more than 1 month is the first diagnostic criteria. And they also talk about this deterioration. So if we take DSM, you can get a better idea about the patient's prognosis or the outcome if you go by the DSM-5 criteria. So they say you would have this deterioration for more than 6 months plus 1 month acute symptoms, the positive symptoms, right? Or some catatonic or negative symptoms for more than 1 month. And deterioration should be there for more than 6 months to diagnose schizophrenia. And not only that, DSM-5 always talk about excluding other disorders such as schizoaffective disorder, major depressive disorder, bipolar affective disorder, right? And substance use disorders directly associated with the illness, right? Or autistic spectrum disorder. We have to exclude some of the other illnesses as well, like autism, substance-induced psychosis, bipolar disorder, schizoaffective disorder, right? To diagnose schizophrenia. If the patient is having severe depression and some psychotic symptoms, right? Secondary to that, the patient is not having schizophrenia. Instead, the patient is having severe depression with psychosis. Or when the patient is having bipolar affective disorder, current episode mania with psychosis. The patient may present with grandiose delusions, right, and expansivity. Then it doesn't become schizophrenia. It becomes mania with psychosis. So in the exam also, you have to be careful. Sometimes you might get patients with psychosis, but it may not always be schizophrenia. Right? You can have psychosis associated with depression, associated with mania, or you can have delusional disorders, right? Or schizoaffective disorder. In schizoaffective disorder, there's a continuation, there's a uninterrupted, right, presence of uh, symptoms of schizophrenia plus symptoms of a mood disorder. There could be schizomanic, schizodepressive, schizomixed, right, picture in schizoaffective disorder. So always don't jump into conclusion that the patient is schizophrenia if you see patient with psychosis. It can be due to something else, maybe a drug-induced psychosis. As I mentioned, depression is psychosis, mania is psychosis, or schizoaffective disorder. Some patients get organic psychosis as well. Then it is not schizophrenia. Patient can get brief psychosis. It is not schizophrenia. Prognosis is different. The management is different. So don't ever jump into conclusions when you are diagnosing a patient. So ICD-11, they have considered so many other things when they are making these guidelines in the ICD-11. So ICD-11 diagnostic criteria are more or less similar to that of DSM-5, diagnostic criteria of schizophrenia. Right? They are excluding other conditions. Right? They are not very strictly specifying the delusions and hallucinations. Right? That is, they are talking about hallucinations, delusions, thought disorders, negative symptoms, like in ICD, DSM-5 guidelines. So they have considered so many literature, and also they compare different diagnostic guidelines from China, from other Asian countries, from Europe, from America, and different countries when they were making the ICD-11 diagnostic guidelines. So if you take prognostic factors, it's very important, right? Because when you see a patient for the first time with schizophrenia, you have to have a rough idea what the patient's cause of illness would be. As I mentioned earlier, only a minority is getting a complete remission from the illness. The others will get relapses, right? And also some a steady course of deterioration when they have schizophrenia. So we can have a rough idea when we see a patient with the onset of schizophrenia or relapse of schizophrenia about the patient's prognosis. For that, of course, you have to know the good and poor prognostic factors. So it will be very important in the exam too. So sometimes the examiner might ask you, what's your opinion about the patient's prognosis? So you can say the patient is having poor prognosis. Then the examiner will ask, why you say the patient is having poor prognosis? Then you can say, because it's an insidious onset illness. Patient developed illness at a younger age. At the age of 20, patient developed schizophrenia. And there were no precipitating factors. Patient's pre-morbid personality was poor. And I'm sure you might know, when you are taking a full history in the exam, you have to see the patient's pre-morbid personality. There will be anxious pre-morbid personalities, there are dependent personalities, paranoid personalities, there are different pre-morbid personalities. That is the personality patient has before the development of the illness. Because we know after developing conditions, developing illnesses, the personalities could change. Right? And simple and undifferentiated subtype, long duration. Especially if they have the illness for more than 2 years. That shows the bad prognosis. Sometimes we see, especially in this area, right? Patients are brought to take treatment after a great delay. Sometimes they keep the patients at home for many years or many months before taking them to the hospital. They do other rituals, the occult treatments, right, before taking the patient to the hospital. One of the reasons is again the stigma. It's a very stigmatized illness, right? And if the patients have predominant negative symptoms, it's again the bad prognostic factor. When the social support is poor, when they have family history of schizophrenia, that shows that there's a genetic loading for the disorder. And male sex. Males have a prognosis when compared to females. So males, they develop the illness earlier. The average age of onset of illness is early in males, as we discussed in one of the previous slides. And they also have a higher chance of having schizophrenia. The male to female ratio is 1.4 to 1, right? And also, there's a hypothesis. People say males have poorer prognosis because when compared to females, they have less final skills. Right? They have less final skills. That is one of the other reasons people give for males to have a poor prognosis. And people who are single, divorced, or widowed have poor prognosis. And when they're institutionalized, institutionalization, right, is another topic. That is a very important topic. If the patients are in an institute for a long period of time, they develop other features of institutionalization, right? And in the past, when they were locked in the asylums, they had this problem and they were never recovered from this illness. Right? And also, you might see patients with good prognostic factors, such as acute onset of illness, late onset. When they develop illness at the age of 40s, by 50s, they have a better prognosis when compared to a person who developed illness at an earlier age. Right? The presence of precipitating factor. When they have a good premorbid personality, is another good prognostic factor. Paranoid and catatonic subtype. As I explained earlier, simple schizophrenia is a very poor prognosis, and paranoid or catatonic schizophrenia compared to simple schizophrenia is having a better prognosis. When the illness is going for a short duration of period, right, or less than 6 months, when they have predominant positive symptoms, in contrast to having negative symptoms. The persons who are showing positive symptoms and also mood symptoms are having a better prognosis. Females are having a better prognosis. People who are married and who are taking outpatient treatment, in contrast to people who are taking inpatient treatment, institutionalized treatment, are having a better prognostic factors. Right? And there's another prognostic factor, being in a developing country. Right? There are so many controversies about this. Right? If you go through the textbooks, even Oxford, that would say people who are living in developing countries do have a better prognosis when compared to people who are living in developed countries. One of the hypotheses is that people living in developing countries do have lower expressed emotions. On the other hand, people in developed countries, they don't tolerate, right, patients, and they have high hostility, criticism, and sometimes all involvement, giving rise to relapses of the illness, relapses of schizophrenia. So this is a poor prognostic factor. You might get MCQ asking for these good prognostic factors or poor prognostic factors. And even if you are presenting patients, if we have to talk about the prognosis outcome of the patient, we have to remember these facts. So we talk about this recovery model. So earlier, of course, there were so many modules when we are treating patients with psychiatric disorders. We are having this consumer-focused model, right? The family-focused model, and the relatively newer model is the recovery model. It's not new, it's not that new, but relatively it's a newer model. Right? We are talking about the recovery of the patient, recovery model of the patient, right? In recovery model, we try to bring the patient back to his baseline functional level. After developing the illness, you can see in the chart, the patient deteriorates after developing the illness, especially the illness like schizophrenia, right? And then after that, there's a steady pause, and you start treating the patient, and there are fluctuations when the patient is recovering. So our main aim is to give the patient a complete recovery. That is, bringing the patient back to the normal functional level. It is not always the symptom reduction, right? We are not always talking about symptom reduction of the patient. Instead, we are talking about recovering the patient, right? And integrate the patient back to the community, right? So it is called the recovery model. Yeah, so there's a question. So how do we differentiate a patient presented with schizophrenia and a patient presented with mania with psychotic symptoms? Yes, that's a very good question. With schizophrenia, so again, we have to go by the diagnostic guidelines, ICD-10 or DSM-5 diagnostic guidelines. With schizophrenia, you have this specific diagnostic criteria to diagnose it. But in mania, you have three clusters of symptoms. One thing is overactivity, the hyperactivity, right? Patient doesn't sleep, patient is working too much, patient is spending too much of money, there's high libido, right? Things like that. Then patient is a grandiose. Right? There could be expansive ideas, grandiose delusions, right? Grandiose delusions of, there are two types of grandiose delusions of ability and grandiose delusions of identity. Patient may believe that he's going to be the next president of the USA, right? Or the patient can change the weather. Patient can heal people. Those are delusions of ability, grandiose delusions of ability. Right? So that's the second symptom cluster. The third one is irritability or elation. Patient can be elated, it can be high, right? Uh, that is all familiar, disinhibited. Or patient can be very irritable. So those are the three symptom clusters in mania. So your patient develops psychotic symptoms secondary to these symptom clusters, that is mania with psychosis or schizophrenia. Schizophrenia, of course, you need to have a specific diagnostic criteria as we discussed under ICD-10 or DSM-5, right? I think I answered the question. So it's not very difficult to distinguish mania with psychosis from schizophrenia if you go by the diagnostic guidelines, right? And even if you take the duration of time, mania, the natural course of mania is around 6 months. You can have a manic episode for 6 months average, right? But to diagnose mania, you need the symptoms for just 1 week. It's actually concept, right? Where the patient is having mania, especially mania with psychosis, right? The condition is very severe. You need admission to the hospital most of the time. On the other hand, hypomania, you might manage the patient in the community. Right? The patient is so disturbed, elated, have grandiose delusions, hyperactive, overactive, right? So you can clearly see the patient is panic. Right? So having these three symptom clusters plus psychotic symptoms is diagnostic of mania, right? And psychotic symptoms, of course, they also can have uh, psychotic symptoms that are diagnostic criteria of schizophrenia. Like they can have third person hallucinations, they can have delusions of control, right? They can have bizarre delusions, but most of the time, the psychotic symptoms in mania are mood compatible, right? Congruent with the mood. The best example is grandiose delusion. When the patient is elated, patient can have grandiose delusions, right? They can have bizarre delusions, they can have delusions of control, but the commonest presentation is mood congruent psychotic symptoms such as grandiose delusions. Right. Okay. So back to the recovery. Okay. In the recovery model, right. In the recovery model, we talk about reintegrating the patient to the community. So we give responsibility to the patient as well. Right? Patient has to have the insight about the illness. Patient need to understand his responsibilities to recover from the illness. His responsibility is to go back to the community. His responsibility is toward the family members. Right? And for that purpose, for a person to recover, we have to fulfill so many other things like relationships, accommodation, right? The patient has to get rid of the substances. We have to address the stigma issues, right? We have to give hope to the patient, right? Cognitive coping and living skills, the social skills. That's why we have places such as day centers, right? In day centers, we do psychotherapies as well as we improve the patient's skills. If a patient develops schizophrenia and there's a deterioration of the level of functioning, we try to improve the functional skills of the patient. Day center is a place where we can do that, right? So we better try to employ the patient, right? We have to improve the patient's skills. Right? So with all this, we can integrate the patient back to the community. That should be our main aim. Right? Otherwise, the patient deteriorates, patient will not come to the baseline, right? And patient would end up in a lower level of function. Right? As I said, the engineer I talked about, I saw, right, there's deterioration, and after that, he could not function as an engineer. But we have tried our best to give the skills the patient acquired before patient developed the illness and try to put the patient back to the community as a productive individual. So when we treat schizophrenia, we always have to keep this recovery model in mind. Right? For that, of course, we need a multidisciplinary team. In exam, right? If you are asked for a management of a patient with schizophrenia, right, you can talk about this multidisciplinary management. To holistically manage the patient, you have to address so many issues of the patient: the cognitive issues, the social issues, the psychological issues, right, the employment, then the accommodation, right, high expressed emotions. We have to address the financials of the family. So we have to holistically manage all these issues to make the patient fully recover. Otherwise, it's a half recovery. Patient would not get the full recovery after treatment. Right? So we have to address all these issues when you are treating a patient in the exam also. So this is one of the useful formats, right? For the exams, if you see a case with schizophrenia, yeah, okay. So how differentiate patient with predominant negative symptoms of schizophrenia from depressed or psychosis? All right, yes. Okay. In predominant negative symptoms, right, in depression, of course, again, it's a syndrome, right? Depression syndrome, you have this major criteria and minor criteria, like you have persistent low mood, right? Loss of lack of interest and pressure, and lack of energy. So those are the most important symptoms, the major symptoms of depression, right? And then you have other symptoms such as loss of libido, the guilt, suicidal ideas, loss of concentration and memory, right? And then sleep disturbances and the weight loss in typical depression. And atypical depression can get we can have a weight gain, right? So there are very uh, very there are symptoms, the symptom clusters you need to have to diagnose depression. Right? With this criteria, you can diagnose depression. Especially, you have to consider persistent low mood, lack of interest and pressure, and lack of energy when diagnostic depression. Right? So, in depression and psychosis, you get the depression. So, you have all the predominant symptoms and signs of depression. So, as you know, if you go through the ICD-10, you have 2 by 2 plus 2, 2 plus 3, 2 plus 4, and more, 3 plus 4 or more diagnostic criteria to diagnose mild, moderate, or severe depression. Right? And if the patient is having a psychosis related to that depression, right? Usually the patient develops psychosis later. They develop depression first, and there's a temporal association between the depression and psychosis. Right? They develop depression, and then later they develop psychotic symptoms. And most of the time, these psychotic symptoms are related to the patient's mood, like in mania with psychosis. Right? As an example, patient can develop delusions of guilt. Patient can hear voices, second person auditory hallucinations, right, inside in the patient, right, and command in the patient to commit suicide. And those are the commanding hallucinations are very dangerous. They could be very dangerous. Sometimes there are commanding hallucinations asking the patient to commit suicide. We had a patient, a commanding hallucination, asked the patient, the commanded patient, to run into, jump into a running train. He tried to do that. People got together and blocked him, right? Prevented him doing that. But this commanding hallucination could be very dangerous, right? So there could be mood-related psychotic symptoms like delusions of guilt, and there's another delusion called the nihilistic delusions. There's a syndrome called Cotard syndrome, especially happens in elderly. In Cotard syndrome, elderly people develop a severe depression, and the predominant psychotic symptom is the nihilistic delusions. They don't that their organs are not existing, right? They are penniless, right? And the organs are not functioning, the brain is not functioning, the gut is not functioning. So those are called nihilistic delusions, right? So in depression, So most of the psychotic symptoms are related to the patient's depressed mood. And again, depression comes first and then later, gradually patient develops psychotic symptoms. And you can clearly see the syndrome of depression in patients with depression psychosis. On the other hand, in schizophrenia or in schizoaffective disorder, you can't see this classical symptoms of depression. You can't, in schizoaffective disorder, patient is having an uninterrupted course of schizophrenia and depression. Right? So it's different from depression psychosis. In depression psychosis, they develop depression and later they develop mainly mood controlled delusions or hallucinations. So does tactile hallucinations suggest schizophrenia more than mania? Tactile hallucinations suggest schizophrenia more than mania and psychosis. It is not diagnostic. Yeah, tactile hallucinations are not diagnostic of schizophrenia. So there are other conditions where you get tactile hallucinations. As an example, if you take uh, a formication, there is delusional disorder, delusional parasitosis. Like in delusional parasitosis, you can get tactile hallucinations. You feel, you perceive that there are bugs crawling underneath the skin. Or even in cocaine intoxication, cocaine withdrawal, like alcohol withdrawal, you can develop tactile hallucinations. And even in uh, organic brain disorders, sometimes you can develop tactile hallucinations. So tactile hallucinations do not suggest schizophrenia. It suggests something else, maybe delusional parasitosis, and the delusion is associated with tactile hallucination, uh, substances, right, drug withdrawal, organic psychosis, right, more than schizophrenia. So it is not diagnostic of schizophrenia that tactile hallucinations are not a feature of schizophrenia, right? But in schizophrenia, you still can have tactile hallucinations, but it is not a characteristic of schizophrenia. That's it. Right. Okay, then, yeah. So this is one of the useful formats you can use in the exam. When you manage patients with schizophrenia, so it's very likely that around half of you get a patient with schizophrenia in the exam. So at least if when you write the structured essays, you will get to manage schizophrenias and you will get case scenarios with schizophrenia. Right? So keeping a management format is important, especially in the cases. So the examiner might ask you how to manage this patient. So this is one of the useful formats you can use to manage the patient with schizophrenia. Or even any other psychiatric condition, maybe depression, bipolar affective disorder, right? You can use this form. So first thing is you have to do the risk assessment. Right? And management setting, you always have to decide the management setting early during the patient's assessment. There is an inpatient management or community management. When the patient is having high risks, right? When the patient's social support is not good, patient is having very gross psychotic symptoms, right? And there are risks to self or others, and the patient is not having a very good compliance. The patient might get another relapse after going home because of poor compliance. Then you better admit the patient and manage the patient in the acute inpatient unit. When the patient is having low risks, and if the patient is having a very good community support, social support, right? Patient is well compliant with medications, then of course you will be able to manage the patient in the community. So I'm sure you have heard about the mental health ordinance in Sri Lanka. Right? It's a very old mental health ordinance, very old act, about 100 years old. Right? There are problems with the current mental health ordinance and it's under revision. Right? So we have to you better tell the examiner whether you use the mental health act or ordinance when you are managing this patient. If the patient is having high risks, if the patient is not in a very good sound mind, right? And if you can manage the patient, if you need to manage the patient as an inpatient, right? You better manage the patient under the mental health ordinance. So that's another problem in the mental health ordinance in Sri Lanka. You can manage the patient as an inpatient only at National Institute of Mental Health. Right? In other places like Anuradha Ellepola, can be right, or National Hospital, you can't manage the patient under the mental health orders under involuntary treatment order. This under revision. In the new revised version, you'll be able to manage the patients under ITO or involuntary treatment order in other facilities as well. But the existing ordinance is not giving us the right to manage the patient under involuntary treatment order. So the patients have previous records, medical records, we better review that. Right? We have to see whether the patient is on drugs, whether we can optimize the medicines, what are the investigations the patient had in the past, the patient had ECT in the past, right? So when you're taking a history under your past psychiatric history, you have to mention all these. When the first episode is, right, whether there are any stressors related to the first episode, how many lapses the patient had in the past, right? What were the associated factors of relapses, like precipitating factors, right? And when the patient had ECT in the past, right? When the patient had IM medications in the past, all that has to be mentioned in the past psychiatric history. So in the management, you have to review the previous medical records. And you have to psychoeducate. You have to educate the patient as well as the family members. Right? Because if you label the patient as having schizophrenia, right, they become very difficult. You have to break the bad news to the patient and the family members. Right? Because as I mentioned, there's a lot of stigma attached to psychiatric illnesses, especially illnesses such as schizophrenia. Those are major psychiatric illnesses. Right? So you have to psychoeducate the family members as well as the patient. Right? So you have to talk about the illness, the cause of illness, the management options, right, including ECT, right? And also about the prognosis and the follow-up. Right? That can reassure family members and patients. Then we have to do the relevant investigations. So we'll talk about these investigations when we come to pharmacological treatment, right? And then pharmacological treatment. So you have to find the best medication for the patient. So for schizophrenia, of course, we have to select the antipsychotic, right? So depending on the side effect profile, right? Depending on the patient's circumstances, depending on whether the medication is available in the hospital or not, how costly the medication is, then we decide the pharmacological treatment. Then non-pharmacological treatment like CBT and ECT, right? That's cognitive behavior therapy and electroconvulsive therapy, those are non-pharmacological treatment. And we always have to use the multidisciplinary team. So if we take a psychiatric team, the psychiatric unit, it has different disciplines. My team side, the psychiatrist, then we have registrars, right, and medical officers, then we have occupational therapists, right, social worker, community psychiatry nurse. So the community psychiatry nurses are the ones who go to the community and manage patients with some of the patients are managed with IM medications, right? Dipomodicate, dipofluphenacins, right? So we have around 300 people in the community. So the community psychiatry nurses, CPNs, they every day they go to the community and manage the patients there. If they are relapsed, they admit the patients. Sometimes they bring the patients, right? Other patients stay with the patients, they give the Modicate and other medicines and return. Right? So we have to use the multidisciplinary team. Every discipline in this MDT, multidisciplinary team, is having a particular role. The social worker has to look after the social issues the patient is having. The occupational therapist need to see the improvement of the patient's skills in the community and also in the day center, right? Then registrars will have a particular role, and we have to liaise with other teams like the medical teams, surgical teams, right, gynecology teams, when the patients get particular other problems, right? Yeah. So can we get a disorganized behavior as a negative symptom in schizophrenia? You can have, yeah, in negative symptoms, when you get simple schizophrenia especially, you can have disorganized behavior. You must have seen some patients with chronic schizophrenia, right? Patients with chronic schizophrenia, they can have a mixture of positive symptoms and negative symptoms. And there's no full recovery in this patient. They have residual symptoms, right? Both positive and negative. And they can show disorganized behavior. Right? They can't, their cognitive functions have deteriorated. Right? Their social skills have deteriorated. Right? They get socially isolated. right? They don't take good care of themselves. And disorganized behavior can be uh, predominant in patients with chronic schizophrenia. And you must have heard about hoarding, right? Hoarding, there's a condition called Sina-Scalar syndrome, right? The Sina-Scalar syndrome also, they sometimes hoard. Even schizophrenia, especially patients with chronic schizophrenia, can hoard. Uh, they hoard sometimes, bottle tops, they hoard pieces of paper, pieces of polythene for no reason, right? And nowadays they are talking about this electronic hoarding. They hoard different pictures in a computer. You just, save them without any purpose only. That's another thing. It's called a Diogenes syndrome, right? Diogenes is just a very interesting story about this Diogenes syndrome, about Alexander Great and Diogenes, Alexander Great's teacher, right? So those are very interesting things. So hoarding can be a part of disorganization in chronic schizophrenia too, right? So they can get disorganized behavior as a part of chronic schizophrenia. And then license services and holistic management. And we have to ensure the compliance of the patient. So we take schizophrenia, the mainstay of management is the medication management, drug management. You always have to ensure the compliance of the patient. Sometimes we have to give IM medications, IM depot medications such as IM depot. The most commonly used IM depot preparation is Modicate, fluphenazine. Right? And sometimes some even use fluphenazine, right? And sucralfate. And in other countries, IM risperidone is available, IM haloperidone or olaspin is available as depot preparations. In Sri Lanka also IM risperidone is available, but it's very costly. So we don't use it often. Right? So what we use mainly is IM Modicate, fluphenazine. Right? So we have to always ensure compliance. That's the called compliance therapy. Right? It's like motivational enhancement we use for alcohol and substance dependence. So it is based on that. The structure is similar to that, and we can use compliance therapy to improve the patient's compliance. So simple measures such as pill boxes, and also you educate the family members to remind the patient about their medications, right? And taking the medications in a particular time of the day, every day, is also can improve the patient's compliance. And also you have to simplify the drug regime. Right? Better to give BD or single doses, right? Daily doses, rather than splitting it into 3 or 4 doses per day. So simplifying the drug regime is found to be effective in making patient compliant, right? And also psychoeducation is important in ensuring patient's compliance. So when the patient is recovering from the condition, you can have a discharge for leave plan. Some people call it a parole leave, but that's not the ideal term. So you can give patient leave form, and you can see the patient back in about a couple of weeks and see how the patient has recovered and whether the patient is maintaining the recovery after the discharge. So follow-up management plans need to be there. So there's assertive management, community management, and outpatient clinics for us to follow up patients. So in the management, there's thing called like one of our teachers, Professor Harishchandra Gambhir, is talking always about this triple gem of psychiatry. So he says the triple gem of psychiatry should be detect the disorder early, treat the disorder effectively, and prevent relapses. It's something like primary, secondary, and tertiary prevention is different from that or something like that, right? So we always have to detect the condition early and we have to treat it effectively with pharmacological and non-pharmacological treatment, and we always have to prevent relapses. So for that, of course, we need to have a good compliance. We have to get the involvement of the multidisciplinary team to prevent relapses, right? So if we do these 3 things, effective early detection, effective treatment, and relapse prevention, the patient will get a very good recovery from psychiatric conditions. Right. So a few things about pharmacological treatment. Right. So it's a long list of drugs. So the main antipsychotics we use are divided into 2: the first generation antipsychotics and second generation antipsychotics. Also, it is called typical antipsychotics and atypical antipsychotics, or conventional antipsychotics and newer antipsychotics. So the first generation antipsychotics are the older drugs like chlorpromazine, that is the first antipsychotic, right? Developed first as an antipsychotic. Then we have haloperidol, trifluopiracin, PeMSAA, right? So those are the first generation antipsychotics. Then we have newer antipsychotics such as olanzapine, risperidone, like quetiapine, amisulpiride, haliperidone, right? Those are the newer antipsychotics. So if you take this first generation and second generation antipsychotics, except clozapine, right? Clozapine is a different drug, we'll talk about it later, right? If you take other first and second generation antipsychotics, if you take studies such as KT study, Cutler study, they say the efficacy and effectiveness of first generation and second generation are equal. Right? There's not much difference. There's no significant difference between the first generations and second generations when you talk about the effectiveness and efficacy of this drug. But the difference is when you start developing the side effects of these medicines. The side effect profile of first generations is different from that of second generations. So if you take this landmark studies such as KT and Cutler's, you can see the dropout rate of medications in the second generation category, like newer category, is less. The dropout rate is less with newer antipsychotics when compared to first generation of old antipsychotics, conventional antipsychotics. Right? So the scientific profile has the main difference between first and second generations. Otherwise, efficacy effectiveness wise, they are more or less equal, except clozapine. Clozapine is having a different profile. The blockade of receptors is different when it comes to clozapine, but others are almost the same. The main receptors they block are serotonin 2A receptors and dopamine 2 receptors. That gives rise to this main action. Right? So if you take the side effect profile, generally, first generations do have higher rate of extrapyramidal side effects and hyperprolactinemia. They have more dystonias, they are more prone to develop gynecomastia, galactoria, right? Dystonias, Parkinson's symptoms when compared to second generations. And generally, second generations do have more metabolic side effects when compared to first generations, such as diabetes mellitus, dyslipidemia, obesity, right? Hypertension, and it gives rise to more cardiovascular risks when compared to first generations. But there are exceptions. Right? Not all the drugs follow this scientific profile. But if you take drugs such as risperidone, right? Risperidone is having a higher risk of extrapyramidal side effects when compared to a drug like olanzapine or clozapine, right? And it can give rise to hyperprolactinemia more often when compared to a drug like olanzapine or quetiapine, right? And if you take drugs such as aripiprazole, so aripiprazole is different from other antipsychotics because it's a partial agonist of dopamine receptors. So it has a very, very good side effect profile. Aripiprazole is not giving rise to weight gain, right? It doesn't give rise to dry mouth or sexual problems, right? And the risk of extrapyramidal side effects is very much less, hyperprolactinemia is very much less, right? And sometimes we add aripiprazole to drugs such as olanzapine to reverse metabolic syndrome, like dyslipidemia and diabetes mellitus. So it's a different drug, aripiprazole, right? So there are controversies about its effectiveness when compared to other antipsychotics such as risperidone, but we see it's an effective antipsychotic when given in higher doses, right, like in 30 milligrams, right? But it has a higher chance of giving rise to akathisia. Akathisia is restless legs, right? You can develop restless legs, fidgeting, right? It's a very distressing side effect. Right? And even first generation such as haloperidol, trifluopiracin can give rise to this akathisia problem. So aripiprazole can cure akathisia more often than other antipsychotics, but its other side effects are very much less, like metabolic syndrome. Right? So though we generally talk about the first generation side effect profile and second generation side effect profile, there are exceptions, such as those I mentioned. Right? And so these are the general the doses of medicines we give to the patients. Risperidone for, you can go high in the dose, like you can go up to around 12 to 16 milligrams of risperidone, but this is the average dose we give for the patients, right? So one problem with some of the drugs are some of the second generation act as first generations, right? When you talk about side effects, when we keep on increasing the dose, like in higher doses, sometimes they act as first generations. That's going to be a problem. The other problem is if you take this highly efficacious drugs such as haloperidol, right, or trifluopecin, they can give rise to a condition called neuroleptic malignant syndrome, NMS. Right? So sometimes you'll be asked in the exam, you must have seen patients are being given test doses of IM medications, like 12.5 milligrams of fluphenazine, Medicaid, right, or 20 milligrams of flupentixol, sorry, 10 milligrams of flupentixol. Before given the therapeutic dose, you give half the therapeutic dose as a test dose. Why you do that? Because one thing is they can develop allergic reactions, right, anaphylaxis, right, and the other reason is they can develop EPSC, severe EPSC, when the first dose is given to a drug-naive patient, especially, right, and also the other risk is the patients can develop neuroleptic malignant syndrome. Right? It is a potentially lethal condition. And when the patient develops neuroleptic malignant syndrome, there's stiffness, the patient can get confused, right? And they can get renal failure, acute renal failure because of rhabdomyolysis. Their CPK levels are sky high, thousands, right? And their WBC is high. Sometimes there could be liver damage, right? But there are a lot of problems. You need the help of your medical colleagues to manage neuroleptic malignant syndrome. And you have to stop withhold all your antipsychotics. Right? Sometimes you might have to give ECT or symptom relief of the patient. We have to monitor the input-output. We have to monitor the patient's renal functions because it can be potentially lethal, especially when they develop rhabdomyolysis. Right? So we have to very carefully give this high potential agents to patients, especially for the patients who are drug naive. If you are giving an antipsychotic for the patient for the first time, we have to be very careful. We have to start with a lower dose and we have to gradually increase the dose. Or if you are giving a IM depot preparation, we have to start with a very small dose. Otherwise, the patient can be in trouble. Yeah. So this more about this depot and injections. Right. And a few things about clozapine. So clozapine is found to be effective for patients with resistant schizophrenia. And again, if you go to the literature, you can see other drugs, other first generations and second generations are as effective as clozapine in patients with non-resistant schizophrenia. Right? So clozapine is found to be effective, more effective than other antipsychotics only when it comes to resistant schizophrenia. So definition of resistant schizophrenia is patient is not responding to antipsychotics, more than two antipsychotics, two or more antipsychotics. One of the antipsychotics should be a second generation antipsychotic, like olanzapine or risperidone, right? If the patient is not adequately responding to two or more antipsychotics, one of which is a second generation, given in optimum doses, given for an optimum period of time, the patient is not responding, to call it resistant schizophrenia. Then, of course, the best choice is clozapine because we don't recommend giving multiple drugs, right? Giving combinations of drugs because side effects could be really bad for the patient, right? Instead, we can give clozapine. Right? So clozapine is given for resistant schizophrenia, but unfortunately, only about 1/3 of the patient show a good recovery. 1/3 of the patients with resistant schizophrenia show a good recovery with clozapine. Just another about 2/3 of the patients who do not recover adequately with clozapine. So there's a again a problem, right? And on the other hand, patients can develop even potentially lethal side effects with clozapine, right? They can get bone marrow suppression, there's leukopenia, right? And neutropenia. Patients can develop seizures because seizure threshold can be uh, reduced by drugs such as clozapine, and even drugs such as olanzapine can reduce the seizure threshold, right? And patient can get sedation, right? Too much of sedation. Sometimes patient can get too sedated and they can develop respiratory suppression, and patients can even die if the dose is too high. That's why we start with a very small dose of clozapine, 12.5 milligrams or 25 milligrams of clozapine, right, initially. And then we very gradually increase it up to around 600 to 800 milligrams, right? And when we are increasing dose, we have to be very careful because patients can develop seizures, right? Patients can develop metabolic side effects, and they can get develop cardiomyopathy, right, myocarditis. So those uh, significant side effects are there with clozapine. So I have to be very careful. You have to monitor the patients very carefully when you are starting a patient on clozapine. So first 18 months we have to do WBC weekly. Then rest of the 1 year we have to monitor WBC 2 weeks. And after that, as long as you are giving clozapine, you have to monitor the patient WBC monthly. Right? It is a must. Otherwise, patient can develop very severe side effects such as bone marrow suppression, and that can be potentially lethal. So those are few of the side effects of clozapine. And in the exam, sometimes we ask about this antipsychotic management. Okay, you say the patient is in schizophrenia. I would like to start risperidone for the patient. So if you go abroad and work there, there are certain countries like Australia, they have these policies. In Australia, they have the risperidone first drug policy. So they say the patient is in psychosis, such as schizophrenia. The first selection should be risperidone. Right? If you're starting something else, you have to give a lot of explanations. You have to rationalize yourself, right? Otherwise, you must start the patient on risperidone for the patient with psychosis, right? What is catatonic behavior and vaccine flexibility? Are those under negative symptoms? No, no, the catatonic symptoms are different from negative symptoms. Negative symptoms are mainly like anhedonia, they can develop apathy, slowness of speech, right? And then emotional blunting. Catatonic symptoms are different. Catatonic symptoms are such as rigidity, right? As you mentioned, the vaccine flexibility. And there's another thing called the psychological pillow. The patient is keeping the patient his head above as if the patient is on a pillow, like psychological pillow. And there's thing called the Whitman and MBBS and the psychological obedience, right? Catatonic obedience. So catatonic symptoms are different from negative symptoms. Negative symptoms, as you mentioned, are the abilities of the patient, those are lost. Right? The reactive mode is lost. Right? Patient's the uh, dynamic functionality is lost. Right? Patient's speech is lost. Normal speech is lost. Right? Those are negative symptoms. They are different from that of catatonic behavior. Right? Yeah. So those are the main things about uh, pharmacological management of schizophrenia. So yeah, in the exam, sometimes you may be asked about the common side effects of medications, such as clozapine. So sometimes the medical students say the rare side effect of these drugs. So we are asking about the common side effects, right? You have to mention the common side effects such as the weight gain is common, right? Developing of dyslipidemia and the metabolic syndrome is common. The fever is common, right? Patient develop tachycardia as a common side effect. Then hypersalivation is common. And sedation is common. So those are the common side effects of clozapine. Don't tell the examiner the rare side effects of clozapine. If they are asked for common side effects, tell the common things first. Right. So few things about ECT, right? ECT, there are so many indications for ECT, and if you go by the literature, there are no absolute contraindications for ECT unless there's a contraindication, anesthesia contraindication. Right? If you take ECT, ECT itself is not having absolute contraindications, but we have to be careful if the patient is having recent MI, so those are related contraindications, recent strokes, right? SOL, things like that. And there are indications for ECT. In a psychotic patient, of course, the indications are such as catatonia, right? Catatotic schizophrenia is an indication. Right? If the patient is not responding to other medications, right, and other treatments, you can think of giving ECT to the patient, right? And if the patient is having risk to the self or others as a part of the illness, then you can again consider ECT, right? Electroconvulsive therapy. So in Sri Lanka, of course, most of the patients are receiving bitemporal ECT. In other countries, there are other ways the ECT is being given, right? Sometimes, rarely we give unilateral ECT, especially if we want to avoid cognitive side effects of ECT, we tend to give it unilateral, right? In other countries, they give bifrontal ECT as well. We don't practice it often in Sri Lanka, right? And cognitive behavior therapy for psychosis. It is something that we don't usually talk about. CBT for psychosis. For delusions and hallucinations, right, you can give CBT, cognitive behavior therapy. But not when the patient is acutely disturbed. When the patient is recovering, patient is not acutely disturbed, right? And if the delusions and hallucinations are resistant to medications, right? And it is there for a long period of time, then of course we can think of cognitive behavior therapy. The main thing about CBT for psychosis is that we are trying to give a meaning to the patient's psychosis, hallucinations, delusions, and we are trying to find the root of the image of the delusions and hallucinations, right? And then we tend to let the patient deal with the delusions and hallucinations and giving him an insight. Right? Those are the main strategies to practice when giving CBT for patients with psychosis. Right. So what are the future? We know when you take psychiatry, it is not developing very fast. Right? If you take the last 2 centuries, right, the development of, especially the management options for psychiatric disorders is very slow. Right? We still do not have this precision psychiatry. Right? We don't treat the patient precisely. Like we don't have biomarkers. So there could be a lot of developments in the future. Right? So coordinated special care, right? And we always have to think of shortening of the duration of untreated psychosis. As I mentioned, patients sometimes present very late after the onset of schizophrenia. Right? Sometimes patients stay home for months or years without being treated. Then, of course, prognosis become very poor. Right? So we have to think of treating the patients and shortening the duration of untreated psychosis. That can improve the patient's prognosis. Right? And using of the long-acting injectables, injectable medicines such as risperidone, right, fluphenazine, fluphenazole. So there's a lot of research showing using of EPO medications, EPO IM medications has a better outcome when compared to giving oral medications. Because we have compliance problems, right? And sometimes patients forget to take medications because they have potential side effects of medicines as well as the disorder, right? So that's what this is showing the effectiveness of long-acting IM EPO preparations. And now medications. The best example is star agonist, trace amine associated receptor agonist, right? So in America, they are doing research at the moment. Now they still haven't gone to the trials, trials, human trials yet, and they are doing the animal trials. And they found that star agonist, trace amine associated receptor agonists are very effective in treating schizophrenia and psychosis. And the scientific profile is very much better the patients who are on TAR agonists do not develop hyperactivia, they don't develop metabolic side effects, right? And they don't develop extrapyramidal side effects, right? It found to be a very good agent for the future. If they find that it is a effective drug in human trials that might replace the first generation and second generation antihistamines we use these days, last, right? And it will be the mainstay of treatment in the future. Right? It will take a decade or two for us to get star agonist in practice, but it has a very promising future. Right? Transcranial magnetic stimulation. Some countries they use PMS instead of ECT for patients with mood disorders and psychotic disorders, and trackers to facilitate the adherence of medications, smartphones, and apps. And we are talking about artificial intelligence when we treat psychiatric illnesses in the future, right? That's part of, right, they are discovering biomarkers for psychiatric disorders, especially they have found some biomarkers for Alzheimer's disorder, Alzheimer's disease, Alzheimer's dementia, right? Example is tau 181, right? Just tau 181, they found that tau proteins, especially tau 181, right? The presence of it in the blood is a good biomarker to predict the prognosis of Alzheimer's disorder. Like that, they are trying to find biomarkers for schizophrenia. If that particular biomarker is present, we can say the patient is having partner schizophrenia. So we can say the patient is having simple schizophrenia. There are no genomics and all that, right? They are trying to find certain genes, right, present in schizophrenia. And if we can find those biomarkers, especially in blood, right? Having CSF is not that easy in all the patients, right? In blood, you do a blood test, you find the biomarker, and the presence is showing that the patient is on schizophrenia. Right? And also, you can use artificial intelligence in the future, right? So what we do is, we'll be doing in the future is, we see the patient is having this particular biomarker, patient's age is this, patient's gender is this, right? And patient is having these other comorbid conditions, patient race is this, right? Patient's family history is this, and then if we enter all these facts, the artificial intelligence, right? AI, the artificial intelligence tools will detect what the patient is having, which subcategory of schizophrenia the patient is having, and what is the best choice of medication the patient will be treated with, and how, what duration patient needs treatment for. Right? Like that, artificial intelligence, right? There will be apps in the future, and they'll show the precise management of a particular patient. That we call the precision psychiatry. And some of the medical subspecialties are using precision medicine even now, right? Some of the surgical subspecialties are using precision medicine, precision surgery. Right? In the future, we can expect psychiatry using precision medicine skills. Right? So can we make minor criteria symptoms in ICD-10 as characteristic features in schizophrenia? The thing is like the minor criteria, that is after the ABCD criteria are the characteristic features of schizophrenia. Those are thought insertion, thought withdrawal, thought takeover, thought broadcasting. Then you have delusions of control, voices deciding among themselves, voices giving non-incremental, voices coming from part of the body, and then bizarre delusions. Those are considered as characteristic features of schizophrenia. That's why ICD-10 says presence of at least one of these criteria, right, for more than 1 month is diagnostic of schizophrenia. But the others, rest of the things, the other hallucinations in other modalities, right, associated with half-formed delusions, right, overwhelming ideas, right. Then you have catonic symptoms, negative symptoms, and thought symptoms. They are not taken as characteristic features of schizophrenia. As an example, you can get catatonia in other conditions. Depressive catatonia. In depression, severe depression, a patient can develop catatonia. Organic mood disorder can develop catatonia, right? And bipolar affective disorder, patient can develop catatonia. So those are not considered as characteristic features. But ABC, if you get MCQ, ABCD, first four diagnostic criteria are taken as characteristic features of schizophrenia. So I think that's all I have in my presentation. Yeah, so these are some of the interesting movies done on schizophrenia. Guerrilla marketing or a local thing. And you must have seen A Beautiful Mind, an Oscar-winning film acted by Russell Crowe. And it's one of the best films showing the features of schizophrenia. Right? It's a film that you must watch, right? And you can find them all in Netflix, right? And Shutter Island, Leonardo DiCaprio's Shutter Island is another interesting movie. They show a lot of these positive symptoms of hallucinations, illusions, right? And the way the patient will disturbed, right? Disorganized when the patient is diagnosed with schizophrenia, right? And Black Swan is a good movie. And One Flew Over the Cuckoo's Nest is an old movie, right? Like the main actor is Jack Nicholson. And in that one, you can see if you watch One Flew Over the Cuckoo's Nest, in the past, they used to give ECT without anesthesia, right? Patient is getting so traumatized. That's why in the past, they were talking about fractures. In current day, the newer machines and good anesthesia practices, patients won't get fractures. In those days, patients get fractures, dislocation from limbs, because with strict the patients are being restrained, right? And then they are given ECT without anesthesia. That has been shown in the One Flew Over the Cuckoo's Nest, another nice movie, right? Secret Window is nice. If you have time, you can see some of these movies. Yeah, so some of the references. Yeah, so that's it. If you have any questions, you can ask. We have 2 more minutes. So you can type the question. I try my best to answer. Do you have any questions?
Hi, Anuradha. This is Duminder.
Hello, Duminder.
Hi. Thank you, Anuradha, for that presentation. I think Sayuri had to leave for another meeting.
Okay, Duminder.
So I was asked to take it off from there.
Okay.
So I think students have asked most of the questions, and you had answered during the lecture itself, I suppose.
Yes, that's another check. Yes.
Yeah.
Yeah, that's another question. Shall I answer that?
Any questions, students? You can unmute your mics and
Yeah, there's another question for the chat. 18-year-old girl with schizophrenia on clozapine for 2 years, developed poor sleep and unable to concentrate on studies. Right? Okay. What should we need to do? Whether reduce the dose or change the study method? Okay, so yeah, the question is about an 18-year-old girl with schizophrenia, and she is on clozapine for 2 years and developed poor sleep and unable to concentrate on studies. So the thing is, right, the drugs, the medicines, as well as the disorder itself can give rise to some of the cognitive side effects, like poor concentration. And clozapine, one of the problems with clozapine is it can give rise to sedation. So in this case scenario, the girl has developed poor sleep while on clozapine, right? Maybe the girl may need another sedative to add on to clozapine, right? And unable to concentrate on studies. So cognitive side effects could be a part of extra sleep, excessive sleep, or even sleep deprivation, right? Sometimes patients develop poor concentration and memory when they deprive sleep, right? If it is due to that, we can add another sedative. Clozapine itself is a sedative drug, but we can add another drug like a small dose of benzodiazepine, intermediate or long-acting benzodiazepine such as clonazepam, or we can add a drug like melatonin to improve their sleep, right? If the poor concentration is due to sleep deprivation. And if it is due to clozapine, right, sometimes it can happen as well, especially when the patient is having too much of sedation in the daytime, right? Then, of course, we might have to change the time that clozapine is given. Sometimes there are some people who metabolize these medications late, right? Especially there are some gender differences between drug metabolism, antipsychotic metabolism, and antidepressant metabolism. Some people metabolize the drug date during the day, right? If it's the reason for the person to get too much of sedation during the daytime, right? Then of course we have to give the medication earlier at night. Because it is usually given as a nocturne dose, right? Then of course we give it early. But if it is due to schizophrenia, right? Schizophrenia, as I discussed, right? Schizophrenia itself can give rise to poor cognitive abilities of the patient. In such a case, we have to treat more effective, right? Maybe patient needs some ECT. Maybe we have to increase the dose of clozapine. Right? Then, of course, with the improvement of the disorder, with effective treatment, patient will have less cognitive side effects. So it depends on the cause for the patient to develop lack of concentration during studies. Okay. Yeah. So there are specific time period we have to treat initially in schizophrenia. Yes. So it's always controversial, right? It's always controversial. Still the controversy is going on. Controversy is going on. Some people say if the patient is having, right, there are two schools of thought. One school of thought says if the patient is having high risk to develop schizophrenia, we better start medication even before the patient develops the symptoms of schizophrenia. So the patient, even though the prodrome of schizophrenia, right? If the patient is having high family history, a very strong family history, all the first relatives are affected with schizophrenia, and when the patient is in the 20s, during which time the patient could develop a disorder, develop the disorder, then one school of thought is, okay, you start with an antipsychotic. Right? Another school of thought say you should not start the patient on antipsychotic before the patient develops schizophrenia, because some patients, even though they have a strong family history, strong genetic load, would not develop schizophrenia, right? Unless they get a very strong, right, a very strong stressor. So we should not unnecessarily treat the patient. So those people say, okay, we better wait until the prodrome is on, when the patient is developing early signs of the schizophrenia, right? Then only we start medication. That's what we practice in Sri Lanka, right? We don't treat the patients before they develop symptoms or signs of schizophrenia. Right? So we have to wait at least until the patient develops a prodromal symptoms of schizophrenia. Right? Otherwise, we better keep the patient monitoring. We have to follow up the patient without starting medications, because the side effects of medication themselves can be distressing to the patient. That's what we do. But there are some people, some clinicians who start medications even before the patient develops symptoms of schizophrenia. Okay. Are there any more questions? If an all bedridden patient complains of third-person hallucinations and delusions for a long period of time, do we consider it as schizophrenia, or is it delirium? It can be delirium as well, right? In delirium also, they can get hallucinations, like perceptual disturbances, deceptions, right? And also they can develop delusions. But the difference is in delirium, they have acute confusion. Patients are confused. They are not oriented in time, place, or person. Schizophrenia, there's no deterioration of the patient's orientation in time, place, or person. Right? They are not confused when they have even acute schizophrenia. They have orientation for time, place, and person. On the other hand, delirium, right, is a condition where the patient is in acute confusion state. Right? So for how long we should continue the treatment? This is lifelong. Not always, right? So the guideline is that the patient has first episode of schizophrenia, we have to treat for at least 2 years, right? If the patient develops subsequent episodes, we have to treat for at least 5 years from remission, right? And sometimes the patient is having frequent episodes of relapses, and the patient's relapses is very high costly. The cost of relapse is very high, right? Then of course we have to consider giving the patient lifelong treatment. Otherwise, 2 years from remission for the first episode, at least 5 years from remission for the second and subsequent episodes. Any more questions? I think whether in the absence of any more questions, we will be able to write the presentation. Do we have any more questions, or can we conclude? So, Gurudh, I think
Yes, Anuradha. So in the absence of any question, I think we can conclude this session. So thanks once again on behalf of PeMSAA and all the participants for taking your time and doing this excellent presentation. I'm sure that we all have learned a lot from your experience. So it's good to see you again, Anuradha. And
okay, thank you so much, Govinda.
Thanks, and then okay,
and
good
you must
night.
be tired after MD part 2 today, right? And thank you so much for having me here, and having a nice audience. And you asked a lot of questions, very interesting questions, very important questions. And wish you all the best for the student studies and exams. And again, thank you very much for having me here. And good night. Thank you.